Okay, so for the next little while, I'm going to try and justify why we should have M&M rounds. And in due course, I'm going to also share with you what I've learned from experts on how we should be running this. And hopefully at the end of the talk, I'll be able to propose what I think we should be doing to get going. So why really should we be holding these M&M rounds? Well, it all boils down to medical error. We are human beings, and as a result, we are fallible animals, and we are going to make mistakes. And mistakes cost lives, and they disable people and injure people in the hospitals. So, does anyone know what medical error is? Well, there's a lot of definitions in the literature. Basically, it is doing something unintended or having an unintended result. Some people also define it as a deviation from normal processes, which may or may cause harm. So what is the scope of the problem? Well, historically, back in 1984, the Harvard group did a study where they reviewed over 30,000 medical records from 51 acute care hospitals in the New York State. Basically, they discovered that 3.7% of the patients had adverse events, and that led to increased hospital length of stay and permanent or disability at the time of discharge. And of all this, it was thought that 69% were due to error and potentially preventable. 11 years later, the Australians did a similar study of about just over 14,000 patients. And again, adverse events did occur, this time in 16.6% of patients. Close to 14% had resulted in permanent disability, and about 5% people died. Of all these, just over half were deemed potentially preventable. This is historical. Come the late 1990s, the Institute of Medicine in America in 1999 produced a landmark paper, so to speak, called "To Err is Human: Building a Safer Health System." This paper actually leaked to the public before it was published, and it created a lot of uproar from the public. People were demanding that the healthcare system does something about human error because people were dying. So, according to this report, 10% of patients who walk into hospital come to some sort of harm. And of all these, 50% were thought to be preventable. And it was estimated that about 44,000 to 98,000 people die every year. And of course, medical error is costly. It was estimated at the time to cost about $2 billion. Not to be outdone, our friends across the pond published their own publication in 2000, which was called An Organization with a Memory. Well, it showed similar results, basically. But the number of people that they estimated to be dying from harm from under our care were about 400 a year, which I think is a gross underestimation. And a lot of people suffered drug reactions. 15% of people suffered nosocomial infections, which were totally preventable from washing hands, they thought at the time. Well, to put things to perspective, you're more likely to die when you walk into hospital than when you walk into your car. And flying is way safer in the workplace. and industrial accidents kill less people than we do. So how does this still compare? Well, for some high-stakes places, there's less than one death in 100,000 encounters. That's in nuclear power, scheduled airline flights, and European railroads. Driving and chemical manufacturing, however, you get one death in between 1,000 and 100,000 encounters. With healthcare and things like mountain climbing and bungee jumping, more than one person would die per 1,000 encounters. More recently, in May this year, there was a paper that was published by a group from Johns Hopkins. Basically, they concluded that if medical error were a cause of death that appeared on death certificates, it would be the third cause of death in America. This was met with a lot of criticism from people in terms of how the numbers were reached. But it doesn't take away the fact that we should all take patient safety seriously. And we should try and prevent harm and death occurring in our praxis. This group summarized the latest results and publications regarding the incidence of medical error. Adverse events still occur in people. The incidence ranges between 3% and 33%, and about 1% of people, 1% on average, die from adverse events. In terms of the numbers, estimated numbers of people that die every year as a result of medical error, well, different studies came up with different extrapolations. Basically, it's a lot more than 44,000 in the 98,000 that was originally estimated in 1999. At least 130 people die every year in the States. Between 130 and 400,000 people die every year. So, after the To Err's human publication, the Institute of Medicine came up with the notion that we all needed to deliver quality care to our patient care to our clients. And it had 6 dimensions. Safety, it had to be patient-centered, effective, timely, and equitable. Well, what is quality care? What does it translate to? Does anyone recognize this fancy statistical sign at all?
Sigma. 6 Sigma.
6 Sigma. Do you know what it means? Well, this was actually coined by Motorola in 1996. It's a measure of quality of product. It's the maximum achievable statistical result. If your product measures Sigma 6, it means it's nearly perfect. For a process to achieve that, you need less than 3.4 defects per million. It's as close to perfect as it can be. Anesthesia, if you try and punch those numbers, scores between 3 and 4. Well, the rest of the healthcare, about 1 to 2, which is at par with like baggage handling at airports, the IRS, and poorly performing restaurants. So, there's no doubt that patient safety is important. People who walk into hospitals are going to come to some harm, and it affects the patients, their loved ones, and we are the secondary or tertiary victims of medical mistakes. So, there's a lot of definitions again of patient safety. It is basically the absence of harm, of preventable harm to a patient during the process of healthcare. There's other definitions which basically mean the same, but the last one, which is like a patient's definition, is really interesting. It is the ability and interest of patients to leave and return home in one piece. James Reason is a professor of psychology at the University of Manchester. A lot of us will know of James Reason. A lot of what I'm saying is not new, but I'll say it anyways. So in 1990, he published a paper on human factors in medicine. Human factors are a major contributor to the adverse events that occur in hospital. And he summarized that we cannot change the human condition, but we can change the conditions under which humans work. The key from his message was we should focus on how systems can prevent the infallible human being from making error. There's his picture. And we all know his Swiss cheese model, but I will show it to you anyway. In order for a little mouse to cross this block of Swiss cheese pattern, there have to be holes that line up. These will be latent conditions, latent or barriers, so to speak, and this could be the active failure that leads to the adverse event. Taking this one as an example, history was not obtained about a patient's allergy, and then the doctor prescribes that drug to which the patient is allergic. Pharmacy does not check the patient's allergy status again. So does the nurse who gives the patient a drug, and the patient arrests. There was a huge drive to come up with national bodies of patient safety. The Australians were actually the first ones. In 1998, a group of enthusiastic physicians in Australia realized that, in healthcare, patient safety issues were not deemed a priority, and they made it a point to come up with a system to help their patients without the help of anyone by doing research and encouraging patient safety. They've got a very fantastic AIMS report of which is widely used in Australia, and they've made a lot of changes. The National Patient Safety Foundation was formed in 1999 in the States. The National Patient Safety Agency was formed in the UK in 2000. In 2003, the Canadian Patient Safety Institute was established. And internationally, the WHO has a World Alliance for Patient Safety. In terms of anesthesia, the Anesthesia Patient Safety Foundation, which was founded in 1985 under the auspices of the American Society of Anesthesia, was formed first. It is very active, and it is widely quoted as a leader in patient safety in healthcare in general. I'm not sure when the Safe Anesthesia UK liaison group was formed, but it is also active, and they produce a lot of guidelines, protocol, and publications too. Here in Canada, so the CAS is a patient safety committee, but I couldn't really see how active they are from their website. By the time an accident or serious harm happens, underneath that surface, there's a lot of accidents waiting to happen, near misses, and preventable situations that occur. What does that mean? We have the tip of the iceberg here, and below there we have thousands of latent conditions. then incidents that are lesser in number, then serious incidents. By the time you get to the big guns like death, there's a few of them, but what lies beneath is something we could try and deal with to prevent this. Hence the M&M rounds. This gentleman called Martin Bromley from the United Kingdom. He's an airline pilot who, unfortunately, I think most of us would have seen his video. He lost his wife, who was scheduled to have an elective minor ENT surgery, secondary to a failed intubation. His video is very powerful and profound. This gentleman has done a lot of work to try and create something good out of the unfortunate loss of his wife that he had. He's taken it upon himself to teach people in healthcare about human factors, and he chairs the clinical human factors group, which is they are always invited internationally and in the UK to try and teach people about how human factors can be corrected. Towards the end of his video, he says something very strong and profound. He said, "We are all wrong, no matter how good we are." Just to spare you from listening to my voice all the time, I'm just going to show a little clip to try and bring home the idea that really medical mistakes are made and they affect everybody. The volume on the system is not working, so just bear with me.
We all have this inherent thing that we trust doctors and nurses that they know what they're doing, but this mistake occurred right under our noses, that the nurse didn't bother to look at the dosage on the bottle. It was 10 units that our kids are supposed to get. They got 10,000, and what it did is it basically turned their blood to the consistency of water. They had a complete inability to clot, and they were basically bleeding out at that point.
He had a small cyst on this side of his face. The doctor referred him to an ENT doctor who recommended that the cyst be removed. On the way home, we already noticed that he started to bleed, and the bleeding was profuse. They said that we have to bring him to the emergency room because of the amount of blood that was coming out. Plus, the cause of that is the one of the artery, I think, was cut. So they have to cauterize it, and they have to put him to sleep. The next thing we noticed when we were waiting at the lobby, at the hallway, was there was a code blue. The tube was not placed on the right place where it should go.
Okay, which brings me to M&M rounds. Events have occurred, events are occurring, and events will continue to occur. M&M rounds are a way for us to proactively deal with patient safety and try and make a difference ourselves. I am not making light of the good job and excellent job that we do all the time, but we are far from perfect. We should report, recognize, and mitigate from errors. According to some patient safety experts, this should be a core activity for all practicing physicians. we need to confront our errors so that we uphold patient safety all the time. M&M rounds were started in the early 1900s by a gentleman called Ernest Codman at the MGH. He faced a lot of opposition from his own department. They were not very happy that he was doing what he was doing, and he actually lost his privileges as a result. However, the American College of Surgeons adopted his model in 1916, I believe. And about 15 years later, the Department of Anesthesia in Philadelphia formed an anesthesia safety committee, which was also modeled around Mr. Codman's work. In our line of work, we never work together. We work with other disciplines. And I think M&M rounds are a way of just making our walls transparent between each other as peers. Our practice is largely solitary until we run into problems. And it's a good way of just learning from each other. So, because I didn't know how to run these, I've worked in places where they were held regularly, but I never coordinated any MMR rounds. I spoke to Hugh Dept and tried to find out, what his experience was. I'll tell you about that in a moment. So I did some soul searching and thought maybe I should just troll through the literature and find out how we should be doing this. A group from Australia, from the University of Monash, within the last year sat down and trolled through the literature already and summarized everything for me, which made my life easier. They looked at why we should be doing this, right? Well, it's to improve patient management, teaching, patient safety, and quality of care. And they emphasize that good M&M rounds should identify adverse events, foster discussion around them, disseminate information to team members about the patient care information. They should reinforce accountability in everyone involved and create a forum to discuss and acknowledge error. They also looked at whether M&M rounds had actually made a difference. The truth is yes. There's a lot of publications that suggest that. So, I guess the biggest for me, the interesting one for me, was the reduction in mortality. In one study, mortality was reduced by 40% in a surgical department, which held M&M rounds every year for 4 years. And there was another study which showed that M&M rounds also reduced death from cholera. A lot of studies emphasize that they create a safe forum, a safe haven for us to discuss errors, especially between junior staff, trainees, and senior staff, including fear of incrimination. It is also a way of encouraging and forcing institutions and systems to change. And it's been shown that patient quality of care and safety does improve. The other interesting thing is that education and retention of knowledge is also improved. In one study of residents in medicine, it was shown that although by and large the trainees were hesitant to come forward with cases, those who did felt that they retained knowledge better and they felt better equipped to manage such similar patients. They've also been shown to improve teaching skills and leadership, and by and large, a lot of physicians who were involved in MMR rounds were satisfied. There was also a reduction in malpractice claims. They also looked at the selection of cases that were presented. Well, it was a whole variety from near misses to complaints to serious incidents. I was very interested in how the experts think we should be conducting these. Well, the timing, there's no consensus. People do have these rounds anywhere from weekly to every 3 to 4 months. Every month seems to be the generally accepted practical way of doing it. How long should each case be? I guess it depends, but they are recommending that in order for people to have a chance to present, maybe each presentation should be about 20 minutes to allow 15 minutes for the presentation and 5 minutes for questions. This is the interesting one. Who should lead or coordinate or facilitate these meetings? They say it is supposed to be a highly skilled expert in patient safety. That's not me.
Ophillia.
That's not me. And there's no fixed way of convening this. I'm just learning. Ideally, it's supposed to be a multidisciplinary thing because we don't work in isolation as anesthesiologists. When stuff happens, it happens in our clinical setting, which is like a Christmas tree. Location, well, people tend to hold them in lecture room types or maybe conference room types of situations. They also recommended that in order for it to be efficient, it needs to be structured. And the S-bar method is recommended and is the most structured and best evaluated so far. It was started in Oregon by a vascular surgeon to try and improve the quality of MMR rounds for their residents, and it's been widely accepted worldwide.
What's S-bar?
S-bar is summary for situation, background, assess, analyze, review literature, and recommend. This was also very interesting. MMR rounds are counterproductive if the environment is not conducive. The key has to be it's a learning meeting, it's a learning process. So the atmosphere should be conducive to discussion to allow participants to contribute. People should avoid shaming and embarrassing each other. We should focus on process or institutional or system improvement as opposed to zoning in on the individual. Yes, we should learn from each other, but people will feel put down if they are blamed. Very importantly, recommendations and implementations to prevent such similar incidents are key to try and making sure that your MMR rounds are successful. They also recommend root cause analysis in some cases. We are supposed to have terms of reference when we do have MMR rounds. If anyone is interested in helping me to come up with meaningful terms of reference, I'll be very happy to accept that offer. They also say that we should have an agenda which should be sent a week in advance. And we should have minutes that are detailed. This is not practical in our situation because of the limitations that we get from our better health services. There should be some sort of governance if you're going to do this properly, and leadership and risk management should be involved in the findings, and open communication is key. So, as individuals and professionals, we have our own responsibilities. The system is also responsible to make it easy for us to see our errors. there should be a just culture of safety that allows anyone to speak up about error, and we should be free to do that. And then we should be able to respond to that error once we've reported the error, and this is facilitated by M&M rounds. As a result, there will be less frequent error, and we'll continue to learn from error. Okay, which brings us back home. I've been here for about 9 years. Initially, in the first 3 or so years, maybe we used to have M&M rounds, I would say rarely, when people chose to use an M&M as their ground round topic. And then when Hugh David came, we used to have them about 3 to 4 times a year. We've not had any multidisciplinary rounds to date, as far as I know. According to Hugh, the most frustrating thing was we are not very forthcoming when it comes to volunteering to share our experiences. It's either the system is so perfect that we don't have cases to report, or something needs to be done. At the time, we were free to go to Hugh and tell him about our cases or email him, but he used to get some, and he said there used to be some people who used to report and some never did. We've had the blue card system, which I'm sure everyone is familiar with. And the trouble was we never used to get any feedback from them, and it looks like people are reporting less and less. Is anyone familiar with the RLS system? This is available. This is the report and learning system. It's a term which was coined to try and encourage everyone in the AHS to report any safety incidents online and to support the just culture of safety. But obviously the fact that some of us don't know it means it's not that widely known, and hence it's underutilized. So I tried to look into reporting as a result. What do they say? If reporting is not voluntary, it's not very productive. People need to be motivated to report and do so voluntarily at their own free will in order for things to work. If you do things that way, you get more results. And some authors say that the willingness to report is a prerequisite to a safer healthcare. And when people report, it means that there's good staff morale as well and safety consciousness. So, what do they say about things that make people report more? Well, if you want people to report more, it needs to be voluntary, confidential. People need to have the right to anonymity. It has to be consistent. There should be clear instructions regarding the ground rules on what's acceptable and not acceptable. And we have to accept that humans are perfect. Not. There should be regular teaching about safety if you want people to report. The system should be supportive. And when there's learners and less experienced people, they should be treated with respect and as professionals. And there should be a blame-free culture. It destroys fear. When the M&M runs are well run, with good communication and leadership support, they work better. And the culture, the just culture, which is non-punitive, is a must. There are a lot of barriers to support us to successful reporting that are reported in literature. The most common one is fear. People are afraid for many reasons. They're afraid to lose jobs, to lose their reputation, to be judged. And there is this expectation of perfection and infallibility amongst physicians too, which is potentially counterproductive. And organizations don't want to lose their staff.
Sorry, back up one slide. So that thing about the lawsuits, that's allegedly one of the concerns about the confidentiality, that the M&Ms could then be accessed or used by lawyers in the
Yes.
lawsuit. So that was, I don't know if that's true or not.
Yeah,
Argument.
that is one of the arguments, and I'll talk about that in a subsequent slide shortly. Okay, so how do I propose that I get people reporting? Well, I'm smiling at you and asking you to kindly please come forward with your cases and reports. I think if a significant event happens, I think we owe it to ourselves, the patient and others, to report that voluntarily. We should utilize the blue card system and the RLS. And I think we should open it up to not cases only. If anything safety related that bugs you, we should share it. There were hospitals that used to have like old school type consultants in the UK, where when you would stand up to present a case, you were like in a court of law. You'd be hung to dry. So to try and discourage people from doing that and making it a totally learning exercise, some departments introduced anonymous presentations. You just give the case with facts to a person who was not involved, and they'll present it for you. And then you just concentrate on how you can learn from the case rather than trying to fry the poor person who was involved in the unfortunate incident. Let's also focus on the system rather than the individual. So I propose that we should, when we hold this, we should all hold the basic assumption that all the participants during these rounds are capable, intelligent, and care about doing their best and want to improve patient safety. As a result, we should be respectful, courteous, and curious when we work together. In the unlikely event that there will be some deviations, they should be flagged in a non-confrontational manner, and that is not my job only. Everyone who participates and notices those deviations should flag them. Forget about M&M rounds. We are governed by AHS rules. So what we traditionally know as M&M rounds should be called educational case reviews. These are not covered by Section 9 of the Alberta Health Act, which comes to, so what it means is then anything that you use there could be used as evidence in court. But that's why they recommend that, it should be an educational activity only, de-identify patient details, present the case, and ask specific questions and see how things can be done differently, and then present the literature to try and support your recommendations and actions. So many people would be hesitant because they think things will be reported in a court of law, but there's no documentation of the minutes. This is why I say it's not applicable to us to document every case that's presented with the details, because that information can be used in a court of law. But, however, we can still document the recommendations that emanate from that and the actions, which is, I think, the most important part of these educational case reviews. I won't say M&M rounds from now on. Okay, so I propose that we call these patient safety rounds just for the next 12 months and see how it works. In order for us to continue proactively talking about and teaching each other about safety, these will include largely educational case reviews, and that includes everything. If you remember that iceberg picture. Also, if you have that bug me list. I remember incessantly bugging Team Year every so often with my bug me list. I could be responsible for you stepping down. I don't know. Okay? Mike Old helped me a lot over the summer because he works for the patient in the patient safety office. I will have access to, when we fill the blue cards out, they are actually entered into the reported learning system as well. So I have access to those so that we can have the opportunity to report some of them back to you and discuss what comes out of them. These may also include a patient safety educational talk from someone knowledgeable or who will have done some work about patient safety. I propose that we have these every month, and so far, Friday rounds are over. They are busy. Every month we have a staff meeting that leaves 3 Fridays. Sometimes we have combined CV rounds that leaves 2 of them. So they are really over subscribed, and we need time to do this. So I propose that the residents have teaching at 6:30 on Wednesday mornings. Craig Needham allowed us to use the first Wednesday of each month to try and do this. Some Fridays would be nice, though.
So, sorry, Ophillia. One thing we could do is have a parallel session with the CV rounds. CV rounds are once a month. Let's see. CV. There are no CV people here.
Well, actually, they have rounds in ECHO right now, so we already run the parallel rounds.
Okay.
So
I'm just putting it out there. I personally would support it. I think it's a good idea that not every CV round we would have them, but certainly maybe half of them.
I think
Once
that
a
would be
CV
great.
round?
Yeah.
Well, they have them once a month.
Like on Wednesday mornings or
On
when?
Fridays.
On Fridays.
Oh, I see what you're talking
I think there's
Well, I think that
I have nothing against CV. I think there's
I think so
a
too.
bigger bias towards them. And sometimes some of the cases are not really appropriate for people who don't do CV all the time. Some of the rounds, though, are appropriate. So I don't know. I think I agree with you.
What about 4 o'clock instead of 6:30 a.m.? Like, would that be better for last thing in the afternoon?
That's a good idea, too. But sometimes the lists overrun.
No, I understand that, but
Somewhat.
you weigh the loss you're going to get from people's lists overrunning, people just getting tired and going home,
Yeah.
versus the enormous sort of cultural change of having to get out of bed at 5 to get here at 6:30.
It's good, too. We can try that. If I get cases
know,
coming,
I'll put that out.
if I get people volunteering and showing me that I have a lot of cases, we'll try and fit them in wherever. Friday round, after 4, and maybe every first Wednesday of the month, too. We should aim to get some multidisciplinary rounds, maybe 3 or 4 times a year. And this is work in progress. I've garnered a team, and my team is all of you, but there's people who've agreed to help me. Susan Holiday and Jamie Seamy have agreed that they will be helping me to try and coordinate these. So I'm simply just a patient safety rounds coordinator. It doesn't suggest that you're going to hear about my cases all the time. Without the cases and incidents and the active audiences and actual action that comes out of it, there's no point in holding the patient safety rounds. So I am appealing to you and begging you to come on board. Let's just join the paradigm shift and jump into the bandwagon and pull the bull by its horns and work together as a team. I foresee that a lot of recommendations and actions are going to come out of these, and I need people to volunteer to try and help with these, be it coming up with protocols or setting up a committee about something so big and important. We will keep the communication lines open, and we'll try and keep a record of all the changes that are going to come out of the patient safety rounds from now on. Well, you've heard my voice for long enough. I'm just going to conclude by giving you an African proverb, which says it takes both rain and sunshine to make a rainbow. I guess or the rain are the incidents that occur. The sunshine is what we are going to do about them during our patient safety rounds. And then the recommendations and actions that are going to emanate from that are going to be our rainbow. And hopefully they're going to be setting an example maybe in the city for other departments to do the same thing too. Thank you very much.